My name is Shivam Srivastav, and it's my pleasure to welcome you to today's webinar. Today, our focus is on a topic that has sparked both enthusiasm and introspection in the medical and technological communities. Is the AI doctor now, or will it shrink or widen global health gaps in the algorithmic age? In the rapidly evolving algorithmic age, artificial intelligence is no longer just a supportive tool. It is beginning to reshape the contour of modern medicine, from enhancing the diagnostic accuracy to optimizing clinical workflows, and also delivering the real time public health insights. AI footprints in healthcare is, of course, growing, and yet this is a progress that brings with it critical ethical and operational challenges. So today's session brings together a panel of distinguished experts who sit at the intersection of healthcare, artificial intelligence, policy, and innovation. So together we will examine not just the potential of AI to revolutionize the medicine, but also framework that is needed to ensure that this revolution is inclusive, equitable, and contextually grounded. So, before we dive into today's discussion, I would like to invite Mr. Venkatesh to introduce the aims and the ongoing initiatives of CSITM.
Thanks, Shivam. Good morning, good afternoon, good evening. I am Venkatesh Balakrishnan. I manage the Center for Software and Information Technology Management of IIM Bangalore. On behalf of IIM Bangalore and the center, it's my pleasure to welcome all the distinguished speakers of today and all the participants. Professor Shakari Banerjee is the chairperson of the center, and I would give a 1-minute introduction. CSITM is IIM Bangalore's Center of Excellence in Digital Management, and it has been in existence for 25 years. As we all know, Bangalore, being the IT hub of India, gives a locational advantage to CSITM, and we are connected with researchers, industry leaders, lawmakers, and of course students from within IIM, and also outside. The goals are aligned to promoting knowledge exchange, training, and promoting research. We conduct various events. Some of them are in the format of webinars such as this, and some of them in the format of workshops, and some in the format of seminars, large seminars. And we also host various other events like book launch. Professor Rahul Dey, who is a panelist today, has been the chairperson for a very long time for the center, and he recently launched a book on artificial intelligence, and that was hosted by CSITM. And we request all the participants to follow us in social media and also look for communication from us to take advantage of all our events. And with that, I hand it over to Shivam to take today's event forward. Back to you, Shivam.
Yeah. Shivam, you're muted.
Yeah, I'm so sorry. Yeah. So thank you so much, sir. It is now my pleasure and privilege to introduce our esteemed panelists. So our first speaker is Professor Rema Padman. She is the trustee professor of management science and healthcare informatics at the Carnegie Mellon University Science College. She is also an adjunct professor in the area of biomedical informatics at the University of Pittsburgh School of Medicine. She holds a BTech from IIT Kanpur and a PhD in operation research from the University of Texas at Austin, and a National Library of Medicine Senior Fellowship in Applied Informatics. Her research focuses on informatics, analytics, and data-driven decision, supports particularly in clinical and consumer-facing IT interventions. Recently, she has been working on AI-driven digital therapeutics, including M-Health games and user-generated visual content to improve health literacy among children and adults. Professor Padman is a member of the US National Academia Roundtable on Health Literacy, focusing on AI and patient engagement. She has published extensively and serves on the editorial board of top journals and advises on numerous healthcare analytics projects. Her honors include multiple Best Paper awards, the IBM Faculty Award, Teaching Excellence Recognition, the Buffalini Prize in 2023 for AI in Medicine, and election as a Fellow of American Medical Informatics Association. Our second panelist is Professor Rahul Dey. He holds a BTech from Indian Institute of Technology, Delhi, and an MBA from FMS Delhi University, and a PhD from the University of Pittsburgh. He began his academic journey at the AI in Management Lab of the Cards Graduate School of Business, studying under Nobel laureate Herman Simon and AI pioneers such as Bruce Buchanan and Harry Koppel. Before joining IIM Bangalore, he has taught at several US business schools. At IIM Bangalore, he has served as the Dean of Programs, chaired the Information System area, and led initiatives like Digital Learning Initiative and the Center for Software and IT Management. He was also the first president of AIS India chapter and has served on the boards of IDRBT, the Software Freedom Law Center India, and of course the IIM Bangalore. Professor Day has taught AI, information systems, and other related subjects for over 2 decades. His research spans AI, digital transformation, e governance, open source software, and telemedicine. He has authored 4 academic books, 2 textbook editions, and over 130 scholarly articles. He is a distinguished member of Association for Information Systems, and he has received 3 international Best Paper awards. He held HP Chair professorship and was named one of the India's top 10 AI researchers by Analytics India magazine. Our third panelist is Professor Neeraj K. Jha. He earned his BTech in Electronic and Electrical Communication Engineering from IIT Kanpur and his PhD in Electrical Engineering from the University of Illinois at Urbana-Champaign in 1985. He is a professor of electrical and computer engineering at the Princeton University and has served as associate director of Andlinger Center for Energy and Environment. Professor Jha is a fellow of both the IEEE and ACM and was honored with the Distinguished Alum Award by IIT Kharagpur in 2014. He has co-authored 5 books, including 2 widely used as textbooks, and has served as the editor-in-chief of IEEE Transaction on VLSI system, as well as associate editor for several other IEEE journals. He has authored and co-authored over 490 research papers, including 16 award-winning papers and hold 29 patents. His current research interest lies in algorithm and architecture for machine learning with applications in smart healthcare. Our fourth panelist is Professor Vikram Tiwari. He is a professor of anesthesiology, biomedical informatics, and biostatistics at Vanderbilt University School of Medicine and professor of management at the Owen Graduate School of Management. He also serves as the senior director of surgical analytics for perioperative service at the Vanderbilt University Hospital. Previously, he was an assistant professor of supply chain management at the University of Boston. He holds doctoral degree in decision science and the operation management from Indiana University Bloomington, along with a degree in electronic and communication engineering and an MBA. So Professor Tiwari's research focuses on operational improvement and capacity management in healthcare delivery system. He leads the operation research group in the Department of Anesthesiology and Support System engineering across Vanderbilt University Medical Center. He was a principal investigator on a VA Houston grant to improve operating room efficiency and has co-led several other healthcare projects. He teaches healthcare operation and analytics in Vanderbilt's MBA and MMHC program and has mentored a wide spectrum of learners from the medical student to doctoral candidates. He has published over 40 articles in top journals across operation and healthcare fields. So once again, I warmly welcoming you all to this forum, and we are truly honored to have such distinguished and diverse panel with us today. Let me briefly outline the structure for today's discussion. Each professor will share their perspective for approximately 13 minutes, after which we will transition into an engaging discussion towards the end of the session. We will also open the floor for the question from the audience, and feel free to type in your question as and when they occur to you. The sequence of today's panel presentation will be as follows: Professor Rema Padman, Professor Rahul De, Professor Neeraj Jha, and Professor Vikram Tiwari. So without any further ado, it is my great pleasure to invite Dr. Rema Padman to share her invaluable insights and expertise with us. Over to you, Dr. Padman.
Can you put it in the
Yeah.
slideshow?
Is it visible
Thank
now?
you. Yes, this is good. Thank you very much. Thank you, Shivam, for that kind introduction. And thanks also to the organizers of this webinar and my distinguished colleagues on the panel. And many thanks also to the audience who have kindly joined this session because of their interest in AI for healthcare. So the theme of today's meeting is AI the doctor now? And my answer to that is no, not yet. And so, given that there's still all these gaps that we need to address with the use of AI, the next question then is: will it shrink or widen global health gaps in this algorithmic age? So, I'd like to focus on that. And next slide, please, Shivam. And really pick up on this and the late Dr. Butte's philosophy. So Dr. Butte was a pioneer at the University of California, San Francisco, on the use of data for decision making, starting with clinical and then broadly across the healthcare decision space. And he said his philosophy was that really all the data in the world will not make a difference unless there are people ready to use it. And that really translated his commitment to using data to generate new insights and actionable healthcare improvements. So today I'm asking the question, I'm thinking that really all the AI in the world that is being developed at such a fast and furious pace will not make a difference unless there are people ready to use it. And so the question is, how can AI meet these goals for healthcare, and can it really shrink global health apps? So the next click, please. So I'd like to think about it from two very specific perspectives, and I know my colleagues will address many other aspects. So the first is, and I'll be very brief with respect to the clinician perspective. We have a tremendous supply demand challenge. So just clinician by himself he or herself, we know there are, it's not really quite meeting the demand. AI by itself is not ready. So clinician plus AI, how can we use this combination, the human plus AI, to address the supply demand challenge? And the second perspective, where I would like to spend a little bit more time, is how can the consumer in this consumer driven age, how can the patient plus AI, or broadly consumer plus AI, utilize this information to shrink the global healthcare gap And for that, I strongly believe we need to address the health literacy challenge. So I'll spend a bit more time on that. So next slide, please. So on the clinician plus AI combination, to meet the supply demand challenge, so can you click through, please? Yeah. We know that India has a growing and daunting challenge, and I see the statistics on the ground. The facts on the ground indicate that India would need 2 million additional doctors and maybe more than 3 million nurses by 2034. That's in less than 10 years. And this need is reflected not just in India, but in the US. For example, estimates indicate that US would need at almost 100,000 physicians and more than 100,000 nurses in order to meet the needs of the growing population as well as the aging population. So, what's the potential role of AI as virtual assistant to the clinician to both help increase productivity and care quality and address and shrink the global health gap? And the first is, and so maybe you can just go through all the click through all of them. Yeah. So there are three thoughts that I wanted to highlight here. The first is that there is tremendous heterogeneity in the levels of support that are needed, and at different levels of need. So, for example, we have novice clinicians, advanced clinicians, nursing staff, community health workers, and so on. They all need different levels of support. So, in some cases, maybe we can think of AI as substitution for the work that's currently being done, but that is currently very limited, versus complementing the capabilities, the skills, and knowledge of the individual. And similarly, in the second point is really the skills that are needed in order to that are aligned with the care that is needs to be provided in order to free up physicians to really practice at the top of their skills, training, and knowledge. We need to really upskill the support staff. And finally, again, heterogeneity in terms of spatial, socioeconomic, the health conditions of the population, and so on. We really can we use what kind of AI tools can you be used to complement the needs of the clinicians and staff. And so examples that comes to mind are telehealth, online e-visits, and so where telehealth are supported, telehealth or telemedicine capabilities are supported with the AI-enabled evidence-based guideline management and information that is contextualized to individual patients. A good example that I see in practice these days, and these are these ambient listening programs. Many companies that are producing these programs, they combine natural language processing, generative AI powered technologies that actually passively listen. So they are on mobile devices. The clinicians bring it to the interaction between the patient encounter between the patient and the clinician. It records, passively listens to and records the conversations between clinicians and patients, but additionally uses AI to synthesize, structure the narratives, and input them into the appropriate sections of the electronic health record, and automates the creation of clinical notes and documentation so that the clinician can, at the end, quickly review and sign off on these. And studies are showing that these have really significantly reduced what is known as pajama time, the time that clinicians actually spend documenting the information at the end of the day after they have seen a slew of patients where they don't have time to document. These technologies are really reducing that time. It's freeing up clinicians to really spend time taking care of patients, expanding the availability of clinician time, and hopefully addressing one clinician at a time, addressing the demand, the need to reduce the global health gap. Moving on, next slide, please. To the consumer side of things, I'd like to spend a little time here. As I mentioned, health literacy is a public health challenge worldwide. And studies have shown that a health literate patient is an engaged patient, and an engaged patient has better health outcomes. So, just so that we are all on the same page, health literacy is defined as a degree to which individuals have the capacity to obtain, process, and understand basic information, medical information, and so that they can make the right decisions for themselves and families. And again, the facts are really staggering, both at the international level, in the US, in India, and really around the world. Only 1 in 10 is considered to be proficient in health literacy, and almost 90% are considered to really need significant additional help in dealing with the health environment. So the next slide, please. So just this, you can just click through it quickly, please. So this is I've just captured some of the latest thoughts about the health literacy challenge in India. It's considered to be the most effective medicine. It's a requirement to empower patients. And of course, all of us know that how COVID, the pandemic, has exposed the challenges associated with low health literacy and the inability of consumers and patients to respond to directives and guidelines and end up with poor outcomes. Next slide, please. So in response to these challenges, my colleagues and I have embarked on this research stream to ask this question to see whether digital therapeutics is appropriate for health literacy. That is, we are asking the question, can we design and evaluate AI-enabled recommendation systems to better retrieve appropriate user-generated content for improving patient education, patient engagement, and broadly societal health literacy? And how do we plan to do that? Uh, uh, the idea is to curate, and we are going to social media sources, visual social media sources such as YouTube content. How can we filter large volumes of visual social media content to meet all these criteria? Because we know that a lot of the content on YouTube on health related topics, and believe me, there are more than 100 million plus videos on health related topics just on the YouTube platform. To be able to curate it at scale, we are asking the question, does the video contain medical content? Is it understandable at the average reading level and so on? Does it provide actionable guidance? Is it accurate? Is it inclusive for the population that's intended to be used? Is the source credible? Is it produced by a credible healthcare organization? Are the resources fair and unbiased so that they can be recommended to different levels of users? So we curate these videos to answer all of these questions. Next slide, please. And it's one step at a time. So we first go through a data collection process. Can you click through this, please? Okay, the data collection did not seem to have come up. This is really collecting data from YouTube videos, where we are collecting both YouTube metadata as well as the video content data. And it is annotated, the data is retrieved and annotated. And then we apply a number of advanced machine learning and generative AI language models to answer these questions using face extraction and gender and race detection for inclusivity and representativeness assessment, BiLSTM, recurrent neural network models to classify videos into those contain high levels of medical information versus low levels of information, multi-view learning, co-training based classification for using understandability for trial validated understandability frameworks to classify videos into high versus low understandability. Similarly, multi-head self-attention for multimodal data in the videos, for actionability guidance and source credibility and so on. Once these videos are filtered, curated using these criteria, then they are aggregated to really assess whether the video can be recommended or not. So another classifier. And then the videos that meet all of these criteria are put through an evaluation, a causal evaluation mechanism step to assess video engagement, where we are using collective engagement metrics that are obtained from the YouTube metadata. And once the engagement, those videos, shortlisted videos that meet the engagement criteria are then sent to the experts, the domain experts, as well as consumers, at the end of which we have you start with, let's say, 10,000 videos on diabetes, and you end up with perhaps 200 videos that can then be evaluated by diabetes educators, diabetes doctors, to say, here are 10 videos that are really appropriate for my patient population. And so those are the videos that are then available to the clinician at the point of decision making, so that along with the medication or a treatment for a patient diagnosed with early diabetes, here are three videos that can also be prescribed. So we are thinking of this really as just in time, personalized, contextualized education at the point of need. So this is really an opportunity to engage and educate patients when they need it at the point in the format, and as I said, contextualized to the needs of the patient. Next slide, please. So just moving on. So, okay, that's the data collection. The next one, please. So moving on from the adult education opportunity to the pediatric, we also know that we have troubling trends worldwide with childhood obesity and consequences, adverse health outcomes. And 1 in 10 obese children by 2030 will be from India. Those are the current estimates. So next slide, please. So what we are proposing and what we are undertaking at the current time are really large scale randomized field experiments using an FDA patented pediatric mobile game to educate and engage children and nudge them to improve healthy lifestyle choices and hygiene practices. And the goal of this scientific endeavor is to evaluate the impact of the app and investigate what are the underlying mechanisms that are generating the impact, so that we can then, as needed, re-engineer the game and make them even more powerful. So we are undertaking randomized control field experiments, adaptive behavior modification nudges, as well as game telemetry analysis. Next slide, please. And this is known as a digital vaccine, and we want to evaluate and integrate this digital vaccine that incorporates the science and technology of implicit learning via AI-enabled mobile health game for nudging behavior change using neurocognitive training. And the idea is to embed it in the classroom and use a health education platform that is a gamified environment for engaging and empowering children. Next slide, please. And finally, so the idea is to then demonstrate impact at scale. All the pilot studies that we have done in India, in Botswana, in Singapore, and so on, indicate that this digital vaccine is showing strong positive impact on children's health knowledge and healthy lifestyle choices. We are also engaged at the current time with an ongoing experiment at the Children's Hospital of Pittsburgh to evaluate the efficacy of this intervention for children with type 1 diabetes, really for all types of metabolic conditions. Next slide, please. So just to conclude, the question at this point is that if you really want to shrink the global health gap, the idea is we really need to be able to address the needs and health literacy needs of patients and the management needs of clinicians. And so the question is, can we really do this health literacy by design, that is embed in the development, these two tools in the development of culturally appropriate, precision prevention focused, AI and analytics enabled solutions that promote societal health literacy and patient engagement from an early age for lifelong learning. So, from a design and policy perspective, our focus on cost mitigation. We know healthcare is very costly all over the world, and we also want to build resilience to infectious and chronic diseases and humanitarian disasters. So, this is another opportunity to promote societal health literacy and shrink global health gaps. So, let me stop there, and I'm happy to take questions later on. Thank you.
Thank you, Professor Padman, for your very important presentation and your work on the healthcare literacy, especially into the digital therapeutics and human in the loop system, shows how AI can support better understanding and decision making in healthcare by
Thank you.
combining the patient centered design with the data driven tools. Your research also offers a practical ways to make the digital health solutions more useful and accessible for the different communities. We appreciate your efforts in helping people engage with health information in ways that are very easy to understand and act on. So now it's my pleasure to invite Professor Rahul Dey to continue the discussion.
Thank you.
Thanks, Shivam. I'll just share my slides uh, here. Okay, is that visible?
Yes, sir. Yeah, we can see.
Okay, thank you. Thank you, Shivam, and it's a great pleasure and to be on this panel and also distinction. Uh, I feel I'm in very, very strong company here. I will present to you some research, some collaborators of mine, and I have been doing over the past many years, related mainly to IT and healthcare. And I will begin by posing the problem, something that Dr. Padman has also referred to. Basically, we do have a healthcare challenge in India, which is that India has 1.2 doctors per thousand population, whereas the global average is 1.7. In fact, in developed countries, it's about 3 doctors per thousand population. Besides that, there is also a huge urban-rural divide. There are about The difference is about 4:1 between urban and rural access to doctors. In fact, 32% of hospital beds are in rural areas and 70% are in urban areas. And if you would like to contrast this, 70% of the population in India is in rural areas. The same story holds for nurses and midwives. The urban areas have about 2 per thousand, and rural areas have 0.3 per thousand. So there's a huge, huge gap in healthcare access through trained professionals. And that in many ways has led to the various governments have been looking at telemedicine as a solution. In fact, there is a program by the government called eSanjeevani, which was launched in 2019, just preceding COVID. And already it has treated some close to 400 million patients, and over 200,000 doctors are onboarded. This works through basically an app. So you can literally call in a doctor and speak to that person. Of course, private players are also involved in this, and it's a huge industry. Valuation is very high, around 3 billion, in companies like Practo and Tata 1mg, M-Fine are involved in this. What are they doing? Similar things: remote consultation, e-prescriptions, lab test booking, and so on, making things easier, working through apps. I must say that a big, huge chunk of the spending in India on healthcare comes out of private pockets, and it also goes into the private sector uh, for healthcare provision. Now, what did we do? We did a fair bit of work over several years looking at telemedicine interactions between doctors and patients. Our particular focus was on continued care. So we were looking at a doctor who had performed surgery on some patients who were in a remote area. And since it was difficult for them to travel to him, they used to go on an online consultation mode. In one study, we found some mechanisms, what we are called mechanisms for telemedicine. Three things stood out. One was this whole idea of rich connectivity. So the doctor in his office used to literally create an office atmosphere. Although he was sitting on a camera just like us right now, what you would see in the background were his assistants, the nurses, and his office-like environment. He even had files in front of him which he would leaf through, but he wasn't really reading them as such. He was being informed on screen about that. Then there was fair bit of tutoring of peripheral doctors. There were many junior doctors who were very keen to learn from him and who would be on the call on the remote site along with patients. And then there was the third thing we observed, that many of the patients who were going through long-term care actually became what we called expert patients. They were being molded. Many of them actually knew how to titrate the medication based on their blood reports that had been coming in. So this was one finding. The same study, we wrote another paper on just looking at why people were going, and we found that there were two competing logics that were at play. One was the logic of choice, which was I need to have access and I need to be able to go here or there, meaning go remote or go physically. And this was counterbalanced by the logic of care, which is, okay, is my quality of care going to be good enough? Am I going to get the treatment I think I should get? And between these two choices, patients would make this attempt to either use telemedicine or not use it. Sometimes they would travel to the doctor. So these were two sets of findings that we found from the telemedicine research. Now, let me shift to AI. What's happening in AI? And this is just an overview. AI in being used in the entire, healthcare value chain in India. You find that there are a bunch of startups and established firms in diagnostics, Cure.ai, Niramai, Sigtapul, and so on. In patient care, Narayan Health is very strong on this. They're doing a lot with use of AI in patient care. For surgery, the Da Vinci surgical robot is being widely used now in India. Hospitals are advertising this. Long-term care, where people can repeatedly go back to the doctor, are being practiced. Apollo is very strong on this chain of hospitals. And of course, drug discovery. And I won't go much into this, but there's a whole bunch of startups which are now participating in this. So I'm calling this the value chain, healthcare value chain. Just as an example, I'll put two cases up front. One of them is Niramai. It's a startup that is doing very well. The creator, one of the co-founder is Dr. Geeta Manjunath, and she was just named as one of the top AI researchers in India. What she did was come up with a very low-cost solution for breast cancer screening. This is practically a non-invasive solution. Ladies wear a jacket that basically warms them up, and then you can get a thermal scan. And it has got clearances from the US and also from Europe, and it is growing very, very well. It's got several recognitions and awards. The other one is Narayana. Here, a student of mine and I did work here. Narayana is very strong on technology use. This is a chain of hospitals. It's the big one is posted in Bangalore, uh, south of here. They have huge number of things they do with AI. One of them that we studied carefully was looking at brain scans of stroke patients who come in and making that decision whether to go in for surgery or not. And we did a fair bit of research on this. So one of the concerns, or set of concerns, I'm going to pull up here. One concern that is flagged by this very interesting book, which has come out of Princeton professors, Narayanan and Kapoor, who I'll call this the snake oil effect. The book is called AI and Snake Oil, where they are questioning hype around AI, and they're saying very, very bluntly that a lot of these claims are unverified. Statistically, they are as good as coin tosses. So why are we going so gaga over this? Uh, in our research, we focused on another aspect which we are calling agency. And to illustrate that, I'm going to just ask you to look at these two narratives. I'll read them out very quickly. Uh, uh, First narrative, an old man gets a chest X-ray. The radiologist thinks he has pneumonia. The doctor reviews blood reports and confirms he has pneumonia. Second narrative, an old man gets a chest X-ray and AI system thinks he has pneumonia. The doctor reviews blood reports and confirms he has pneumonia. Now, later on, if we find out that if the old man actually did not have pneumonia, then what is the situation? Now, I'm bringing this up because we are arguing this has to do with the agencies we allocate to the various actors in this decision-making scenario. The X-ray machine, the radiologist, the AI, and the doctor. They're all involved. Now, we said that agency is not a 1-0 situation. It's not like you have agency or you don't. Agency has gradations, and we found that looking at actually philosophy literature, action philosophy, that agencies can be graded on these 6 dimensions. Uh, at the lowest end is passivity, whereas the agent is being acted upon. There's no action. The agent is doing nothing. And then there is slightly more agency when it's automatic. It's like a thermostat, which just responds to its environment. And then there is rationality, where the agent actually has some reasons and beliefs that it uses. And then you have endorsement, where the agent actually is involved in the action and thinks through and reflects on the reasons why certain decisions are made. And above that is freedom, where the agent also has freedom to choose. Now, these are not exclusive categories. One can see this in certain kinds of behaviors. The last one is the conscious one, where the agency has consciousness. We again, consciousness is a very tough subject to categorize. We found there are 2 types people are talking about. One is access consciousness, whether you can reflect on the thoughts and ideas that you're having. And the other is phenomenal consciousness, which is having a qualitative experience of that. Now, when we say that agency can be understood along these dimensions, we said that we can take each of those actors and then see how they are playing out, their agency plays out along these dimensions. And that is what the paper kind of ends with, that once we are looking at these complex systems which have a chain of actors who are involved in the decision making, this agency has to be understood a little bit more deeply. Now, I'll conclude here by saying that in future, as AI will be adopted in India, that's almost guaranteed given our situation that we just don't have enough doctors. And as Dr. Padman also pointed out, there is a need for technically trained doctors and nurses all over the world. We will be taking resort to these technologies like telemedicine and AI. We do have a growing, aging population that will require intensive interventions. What we have to be careful about is this interplay between logic of choice and care. We have to be conscious, doctors have to be conscious that patients should have a choice in this. It is not that they are invariably have to deal with the technology if they don't want to, or deal with the doctor if they don't want. That choice has to come in play. Second, there will be a situation where patients will adapt. It's what we are calling molding of patients. In future, patients will also adapt to how the technology is playing in their lives and what they can do with it. They will begin to see certain affordances of the technology to which they will react. Uh, Doctors, as I said, will have to ensure choice. But lastly, let me conclude by saying regulations have to step up and recognize that there is agency in it. One cannot always hold the one doctor responsible, saying, hey, you messed up, you declared this as pneumonia. Perhaps we have to recognize that there are a chain of actors who are involved in this and who are possibly trying to do their best in solving that problem. One shouldn't always hold some people responsible. I will stop there and take questions later. Thank you so much.
Thank you so much, Professor Day, for your presentation. You showed us that telemedicine is not just about technology, but also about people like doctors, patients, and their communities, and working together and trusting the systems. You also helped us to understand how important it is to balance giving people choices with making sure that they receive good, caring treatment. And your work also helps us to think carefully about how to build a digital health system that works well for everyone. So we truly appreciate your efforts in showing how technology can support public health in real and practical ways. So now it is my pleasure to invite Professor Neeraj Jha to continue the discussion. Over to you, sir.
Hello, everyone. I'm Neeraj Jha from the Department of Electrical and Computer Engineering at Princeton, and my topic today is medical superintelligence. So what do we mean by medical superintelligence? It's really, we envision it as a society of medical AI assistants and AI agents, and the goal is to democratize smart healthcare to underserved populations. And the different aspects of healthcare that AI can tackle would be disease onset detection after the disease has been diagnosed, keeping the person well from extreme episodes of that disease. Interpretability is very important for physicians to have a buy-in. And mostly up till now, we've been applying statistics to individuals. But for the first time now, we are in a position with the help of AI to make personalized medical decision making, where there may be many options available, many interventions or therapies available for a particular patient. Which one is optimal for this particular patient that AI can also give us. So this word superintelligence has different meanings for different people. The way this word is used by the AI industry is to build ultra-large, top-down, omniscient, multimodal models that mimic God. It needs to know everything about everything. The problem with this approach is its insatiable thirst for data, and all the data, the public data from the internet, have already been scraped and used to train these large models that have trillions of parameters. And private data, which is very valuable, is not easily accessible because that's not going to be placed on the web. Another problem is that the projection is, at least in the US, by 2050, 50% of the electricity may go to AI. That is clearly not sustainable because we are already having problems with our CO2 emissions. And during both training of these models and later on at inference time, when billions of people start using these models, for example, if you say sorry or thank you or please to ChatGPT, it consumes a lot of CO2. It emits a lot of CO2 in the atmosphere, which is not good. So you practically need a nuclear reactor to train a single model. That's why data centers are coming up all over the world. And even after spending all of this computation and energy costs, the model still hallucinates. By that, we mean the model is confident and is wrong. Now, in many domains like healthcare, like legal, like business, education, where accuracy is important, this approach doesn't work very well. So let's start with the first component of this ecosystem of assistants and agents. So here is something that we've been developing, health decision support system, where in tier one, you have now smartwatches and smartphones have a lot of sensors, physiological sensors, and it is possible to detect diseases. So you can have an onset detection on your smartwatch. And most of the time, we are not in the clinic or in the hospital. So it's important that if there is an onset, it be detected very quickly. Once it is detected, then you're sent over the clinical boundary to tier two, where you have electronic health records. There may be simple measurements taken, but those measurements may not be enough. So then you're sent to tier three, where a CT scan or MRI or blood test or X-ray, etc., could be done. And finally, you go to tier four, where now the diagnosis has been done and you need a treatment or prescription or lifestyle suggestions. Now, for each disease, and there are 69,000 diseases known to mankind, for each disease and for each tier, there is a machine learning model, and that goes into the diagnosis engine. So let's see an instance of this. So from tier one, this is COVID Deep that can detect COVID and distinguish healthy from asymptomatic and symptomatic COVID. This we had developed in 2020. This paper came out in 2021. And the physiological sensors that you see on the left, blood pressure, galvanic skin response, which is skin conductance, pulse oximeter, etc., skin temperature, heart rate. These are now embedded in smartwatches like Samsung or Apple and others. And there was also a questionnaire with yes, no answer that you can answer through the app. Cough, yes or no, fever, yes or no, loss of taste or smell, yes or no. And in the medical domain, there is never enough training data, real training data. So you also need to draw some synthetic data from the same probability distribution so that you can train the machine learning models to high levels of accuracy. And then finally, you need very compact machine learning models that you can place on the smartwatch and not drain the battery of the smartwatch too quickly. So we have a paradigm called grow and prune paradigm. And ultimately, in this case, the net result is a neural network that can be placed on a smartphone or a smartwatch that can detect COVID. So this was the result. We had 98% accuracy. This is data that we collected from Italy. Then we tested it in France. We still got 97% accuracy from a very different population. The false positive rate is less than 1%. The false negative rate is less than 5%. And you can compare that to RT-PCR, which is the gold standard, where the FPR is 0%, but FNR is 30%. So in the first 2-3 days, RT-PCR is not able to detect COVID. And in that time interval, maybe the person is super spreading the disease to others. So the idea is not limited to COVID. We had also looked at type 1, type 2 diabetes, mental health disorders, bipolar, depression, schizophrenia, and you get 90 to 96% accuracy for these as well. And there is a startup that is commercializing this, and it's going after other diseases as well. Now, if I ask you, at what age do you think you were the smartest? And the definition of smartest is you had the most neurons and connections in your brain. I'm not sure many of you would say at age 2 when you were a toddler, but that is true. You had the most connections and most neurons in your brain when you were 2. So we mimic this paradigm. We start with a baby neural network, and then we grow it to a toddler neural network to increase the accuracy. And then we aggressively prune the network to an adult neural network, which is 100 times smaller, but it's very good for that particular application, for example, COVID or diabetes or whatever it is. So as I mentioned, this neural network can go inside an app. Here, this app is for a smartphone, Samsung smartphone, but we've also put this on the app on a smartwatch, Samsung smartwatch, and it can detect COVID within a minute. In fact, last December, I was coming back from India, and the person next to me was sneezing a lot, so I didn't have my smartwatch with me. When I came back to Princeton, I tested myself. Smartwatch told me I was COVID positive. Then I did a regular test, and in fact, I was COVID positive. So the neural network is quite accurate. So what does this mean? So in terms of democratizing healthcare, so imagine a world where we can detect any disease for $1 per test per disease. So the technology for this already exists, and this could be one way to bridge the urban-rural gaps. Then imagine a world where extreme manifestations, hyperglycemia, hypoglycemia, extreme episodes of depression, they can be detected in real time so that the intervention can happen when it can really benefit the patient. And finally, imagine a world where the interventions are personalized. And for that, we've developed a counterfactual framework that can ask what-if questions. It's called Scout. And among the many therapies possible, it'll pick the best one for that particular individual. So what does this mean? So a lot of people in AI have been saying we don't need radiologists by 2028. This prediction was made 10 years ago, but latest results show that, in fact, the number of radiologists in the US has been going up, not down. So when you have this ability to detect the onset of a disease, then I need more doctors to keep me well. So right now, most of the world, and as you saw in the earlier slides from Dr. Day and Dr. Padman, most of the world is not well served in terms of healthcare. So now with AI making it much less expensive to be able to do disease onset detection, I would need more doctors to keep me well and suggest therapy. So I envision AI as an aid, not a replacement for doctors. So let's go on to medical AI agents, which is another pillar of this ecosystem of AI agents and assistants. So here, I show a knowledge graph. A knowledge graph is really a distillation and abstraction or extracting the rules from text corpora. So we have 14 million papers on PubMed, but no human has the ability to read all the papers, even in his or her domain, or even if they could read it, to retain all of that knowledge. So a knowledge graph is an abstraction which will be on which I can do reasoning. So we don't want to do reasoning on top of large language models because, as I said earlier, they hallucinate and we can't tolerate hallucinations in the medical domain. So this is aided by the episodic and semantic memory. And the inspiration for that comes from neuroscience. So our brain is always predicting what is going to happen next. And if what happens next is not what our brain predicted, it's a surprise. If it's a surprise, that event goes into our hippocampus. And then we go to sleep. The events that are important, they go to our neocortex. So that's where the inspiration from the episodic and semantic memory come in. They won't store data, but they will store rules or abstractions that we can now, or the agent can now generalize with when it sees other novel situations in the future that was not part of the training data. Now, so let's go to a society. So we are building up this society bottom up, not top down like the industry. So what do I want from medical superintelligence? So I want creativity. I want new hypotheses. In fact, I want PhD level questions from AI that people have not thought of, but now these research problems have to be deep. It can't just be breadth of knowledge. It has to have depth of knowledge. It has to have lifelong learning. It should be explainable to a physician and auditable. These knowledge graphs should be auditable and improvable. And we believe that the basis for getting to this medical superintelligence scenario is graph intelligence, and the knowledge graph would be the basis for it. On the right, you see O, which is orchestrator. So you have a query. The physician or the patient has a query. It's in English or in some language. And the orchestrator knows maybe the query is about type 1 diabetes. So the orchestrator knows in the ecosystem of agents and assistants, which is the subgraph or the sub parts of that network where the answer is there. And then it gets the response back from that section of the ecosystem and then delivers the response to the user. So instead of, before we build a whole society, let's build a small family first. So here is one example with 3 members where I've mentioned medical AI assistance for disease onset detection. I've mentioned well-being AI agent to prevent extreme episodes, personalized decision making. And these 3 itself could be a sub-network that would be part of that ecosystem. You can build this for many different diseases. And so we'll build this hierarchically and some possible goals, not at all exhaustive set of goals, but we could do differential diagnosis, distinguish disease from another disease, population level predictions, when there is a pandemic, for example, healthcare policy. How do you know that the bill you're going to pass is actually going to help people? So these are some of the examples. Now you may ask, why just medical superintelligence? Because that's where the data are. So we have a lot of data from PubMed, and that's why we went after medical superintelligence first. But this bottom-up idea of domain-specific superintelligence can be applied to education, legal, business, insurance, contracts, other domains as well. What we need is enough books and papers that are germane to that field so that we can abstract the key features in a knowledge graph and then reason with that knowledge graph. So in conclusions, we are building super intelligence bottom up, not top down. And you see the different pillars, detection, well-being, personalized decision making, and inspiration comes from neuroscience. I mentioned hippocampus and the neocortex. And we want to do reasoning in depth. And knowledge graph lets us do that. We don't want surface level intelligence. We want in-depth intelligence. And so that is what this society can give you. So that's what I have. And later on, I'd be happy to answer any questions that you may have.
Thank you, Professor Jha, for your detailed and thoughtful presentation. Your work on the bottom up medical AI built around small specialized agents presents a new approach to designing the health technologies that are more efficient, flexible, and easier in the use in different healthcare settings. By focusing on explainability, coordination, and particular use of resources, your ideas offer a different path for the large top-down AI models we often hear about. So we appreciate your contribution to thinking about how AI can work alongside doctors to improve patient care. Now it is my pleasure to invite Professor Vikram Tiwari to continue the discussion. Over to you, sir.
Thank you, Shivam. And thank you to all our three presenters so far, Dr. Jha, Dr. Day, and Dr. Padman. Excellent presentations. I think I'm learning a lot. A lot of stuff that I'll talk about has kind of already been covered. But I think it's nice because I will try and get this into the real world. So I think I'm in a unique position being also employed in a medical school and also teaching and researching on operations management stuff, decision sciences stuff. So I have that a real world view and a front seat into how hospitals and academic medical centers are approaching the implementation of AI, and I'll have some few examples to talk through that. So as I said, it's a unique position that I have because I'm employed in the medical center where I am in the anesthesiology department as a faculty. Obviously, I'm not a medical doctor. I have a PhD in operations research and management science, but I also have a role in the hospital in the perioperative services, which is basically the operating room and the surrounding activities of the operating room. So I'm part of that group, but I also do analytics for the hospital. So most of my research that I do comes from real problem contexts that I observe in the hospital. I use those problems to do my research, publish papers, and also use part of that into my teaching at the business school. And then one of the interesting things I am often able to do is use some aspects of it or as much as I can into the real world. And so that's the cycle of my work. And so during this process, I've also become part of at our Vanderbilt University Medical Center. So a little bit about Vanderbilt University Medical Center. It's in Nashville. It's in the state of Tennessee. It's the largest level 1 trauma center in this region. And so we do the most complicated surgeries to the most easiest one, the most complicated patients. And we are the biggest transplant center, probably the biggest transplant center in the country, especially for heart transplants. We get patients from across the world. So we started working on this AI even before the LLMs rush happened. And we have a committee called the Artificial Intelligence Technology Committee. And we had already started observing some of this Dr. Day mentioned about governance and responsible AI, because we were getting bombarded with these vendors with their solutions for radiology, for sepsis, even our own electronic medical record, which is from Epic. They have their own AI infused alerts that they want us to turn on. And so the medical center started feeling that there needs to be an overarching governance around these projects, around these initiatives, and what truly is an AI, and what is our liability if a decision is made based on AI. And also, since patients are coming with their own research that they have done using AI, how should the physicians be talking to them about this kind of work? So we established this committee, and are part of some of the slides I have today are actually from the colleagues in our committee. And over this last 2-3 years, basically what we've learned is that we have the key lesson that we've learned is we have to keep our expectations in check and maintain high reliability practices, particularly based with respect to the AI tools, because AI is exciting, but it can be dangerous. And we are learning that firsthand. So what I'm going to do is I'm going to take you through a couple of just random examples here, just to show this idea of hallucination that Dr. Jha was also talking about, and why we are learning to go at this really very slowly, not slowly, I would say, but very cautiously, and in participation with other medical centers around the world, especially in the US. And in fact, as Dr. Day was talking about, I realized that we are actually part of a system, or of a collaboration called CHAI. So this is for Coalition for Health AI. And it's basically goal is to develop AI solutions that are responsible and essentially are well governed, have been thought through. There is regulation around it. And so all of these partners are in collaboration with the government if they want to influence the regulations that come up, so that it is beneficial for the patients and not otherwise. So here are just a few examples of that hallucination. So one of our colleagues did this. They asked, visually depict a doctor. And this is the image that the AI threw up. So I'm going to ask questions. I'll pause at a few of these slides, and the people in the audience who are able to listen, if you want to throw in your answers in the chat, it'll be really interesting for others to see as well. So a visual depiction of a doctor, nice looking gentleman, nothing wrong with this, seems very feasible. So that's great. So then they asked, create another picture, and we get this. So do you see any interesting observation here? Feel free to type into the chat window. One thing, of course, I think is very obvious is these look like kids to me. They don't look like doctors, probably mid-20s, late 20s, good-looking, white, young boys. Okay, so then let's keep going. Then they asked, create a collage of 20 doctors. So I'm going to pause here for just a second. People, if you can type in what you feel about this picture. AI generated picture of 20 doctors. Obviously, probably it's not too visible, but some of these have very weird faces and features. So obviously AI couldn't figure out some of the stuff. One thing that I've noticed when I was shown this is, I don't know why all the men have beard. Almost all have beards here. So there's something going on with the Okay, so I'm not looking at the chat here, but if somebody has figured out a basic flaw here, you should give yourself a high five. And that basic flaw here is this is not 20. This is in fact 1, 2, 3, 4, 5, 6 times 5, 30 doctors. So just the basic act of giving 20 doctors, the AI kind of messed that up itself. And obviously a little bit biased towards the younger population here. So if you found that it's not 20, I think give yourself a pat on the back. Make an image of 20 people from health IT. So this is health IT is our department actually. And I don't know, there is no health IT in the world that would look like this. And I don't know of any IT persons, you guys are sitting in Bangalore, that wears suit and goes to work in an IT department. Here's another one. We wanted to create one for our own governance. So kind of weird here. Both the ladies are wearing lab coats, but the gentlemen are not. And I don't know where they're looking at each other. And then here is another one. Create an image of artificial governance committee with 20 at a hospital that includes 20 people. So the first thing, again, this is not 20. I counted. I think this is 23 or 24. All the women are in lab coats. All the gentlemen are in suit. all of them are wearing exactly the same shirt and tie, and they weirdly look a lot alike. And so just again, nothing to do with health AI here, but just a point that us in the medical school, in the medical center, are going about this very cautiously and very, very carefully because we understand the risks, and patient care by far is the only objective. And so we can just randomly pick up and start using AI if it is not has been thoroughly vetted. So a couple of just few examples of some of the projects that are going on. But more importantly, what I wanted to show you was the time it takes or the steps that we go through before anything can get implemented. So usually it starts with a model development and validation. And this is where our committee kind of comes into play. We get pitched those ideas, we evaluate them, scrutinize them, help the researcher frame the problem better, help them point them towards the tools that are available. Once that happens, hopefully it gets published. Once the paper is published, we can have a pilot trial if it's approved internally by the departments. It's a pilot trial. If that's successful, that leads to a pragmatic randomized control trial, because by far that's the gold standard in any medical research. If it has to be patient touching, it has to go through a randomized control trial to prove the effectiveness of that intervention. Then the results get published, and once all of that is done, then we start working on figuring out how to implement in the hospital and whether that will help or not. So if you look at the timeline here, just looking at this RCT itself, this could be years itself, and recruiting patients, getting their approvals, and all of that stuff. So this is a huge time. This is years. I was reading an article by the dean of Stanford Medical School, and as per him, usually without AI, at least at this moment, it takes about 17 years for new technologies or new treatments to really be thoroughly vetted and implemented in our medical system. So just a quick example here of some of the projects that are going through. Readmission rate, you see twice. Readmission is when a patient gets discharged from the hospital, but then they get readmitted within a 30-day time period, and the hospital actually gets penalized for those kind of things. So predicting which patients will have a higher probability of readmission is a major issue for us. Hospital at home is for patients that come to the ED and could potentially be admitted, but often if they're not that serious enough, we do let them, we say, you go back home, and we will have a nurse visit you, a physician will visit you periodically, but you are better off being treated at home. And so making a prediction of who is the right candidate. This is acute kidney injury prediction. Again, discharges from the NICU, which is neonatal intensive care unit. This is thrombosis prediction. COVID they were doing, and there's no arrow because we've stopped doing that. Pressure injury, I'll show you some results of the pressure injury prediction and the postpartum hemorrhage models, and you can see they are in the advanced stages. This one actually has reached the pragmatic trial now, so this is moving along nicely. Autoimmune reintubation risk, whether if the patient has to go back into the ECMO, for example. So let me just show you how we actually approach these. So once these projects start, and here's the postpartum hemorrhage. This is Dr. Andy here. She's actually an anesthesiologist. So obviously postpartum is a leading preventable cause for maternal mortality. We have a manual model. This is the manual model results, point-based and only marginally useful, because you can see the AUC area under the curve at 0.59. So just a little better than a coin flip. And this risk prediction model that they've come up with is at 0.81. So it is still not really as good enough that it will be implemented at this stage, because typically we are looking for 0.9, 0.95 at least before we would feel comfortable enough, because this is probably might be just as good as a physician's judgment at this moment. And so all of those things will kind of come out in the randomized control trial. pressure injury prediction. This one's really good. So the standard here is a Braden scale. It's a point dichotomized point system and has been in place since 1987. So these are patients who lay, excuse me, patients who lay on a bed in one position for a very long time have the risk of developing pressure injuries. And obviously, it's a very serious issue from a patient's perspective. So trying to predict that is a key feature. And the Braden AUC you can see is about 0.73 or 0.8 for the continuous Braden scale. And the VUMC model that our people have come up with is at 0.93. So this is really good, and it's right now we are piloting it in one of our cardiovascular intensive care units as well. Dr. Padman talked about this. This is our ambient technology. We call it it's called the Dragon Ambient Experience. As Dr. Padman explained, the physician before this, the physician would be talking to the patient, but also continuously typing notes at the same time. And that interaction used to be a little less personal. And so with this ambient technology, the physician just opens up their app as soon as they start talking to the patient, and they're talking normally, getting consultation, doing the consultation, and not having to worry about typing the notes. The notes get captured in the app. It gets pushed into the EMR, electronic medical record, and the physician can finally choose to either make edits or accept them, but it has definitely helped a lot of the physicians. So we actually did a study, went out and we started asking after this had been going on for about 3-4 months, what the physician's reaction to this is. And it was interesting because what we found was that this was kind of a scale. Some are really happy and some are actually not happy at all with this technology. So who's the most happy? The most happy are our primary care physicians, whose primary interaction is with the patient, and their task is really to talk to the patient, right? Your annual physical exam once a year, you have 30-40 minutes, and you really want to understand what has happened in the patient's life over the past year. And so there is a lot of talking, a lot of note capturing, and that has really helped the primary care physicians. Those who are not too happy are the specialized physicians that have very specific and shorter duration consultations with the patients. So for example, I think one was an eye physician who was doing a post-surgery follow-up, and they have a very specific point-by-point clinically oriented discussion with patients, the exact milligrams and the milliliters of some prescription that needs to be changed or taken. And this technology was missing that a lot, and it was leading a lot of them to actually redo a lot of stuff, which is they felt they could have just done that on their own at the first. So still, I think there is improvement opportunities that exist here, but it's happening. Where we are finding a lot of vendors approaching us, and a real opportunity is actually in the operation side of stuff. And so revenue cycle management, you'll probably hear about this a lot, where all the notes that the physicians are taking, they have to be extracted by our coders. We call them billing coders, to convert that description, those ICD-9, into billing codes, which gets sent to the insurance company, the payers, for seeking reimbursement. So that's a tedious manual process. But using the AI, there are technologies now who can sparse through the notes and extract the information and convert them into codes. And then the biller or the coder can quickly check. So that is helping a lot, speed up things a lot. And then this is where I do a lot of stuff, which is the command center, which is patient flow management. So we have a 900,000 bed hospital and multiple hospitals in the area. We get transfer patients. So needs to be a continuous flow of patients in and out as quickly as possible. And so for those things, we have vendors now that are providing technology for making predictions about which patient is likely can be discharged the next day, what are the potential bottlenecks that could prevent the patient from being discharged, because looks like this patient will need a wheelchair assistance, or this patient does not have a home address, or somebody where they can go. So we need a nursing care for this patient. Has that been arranged? So all of those so far have obviously been manual, but the AI can kind of keep this on running in the background and sending notifications to help speed up with this kind of analysis. So all of that is already implemented. And then finally, one of my research papers that got published, I want to show this just to show you that it is easy, not easy, but the research and the application side of it are kind of two different things. Here we are trying to predict the length of stay of patients who have coronary artery bypass grafting CABG surgery. So our model is better than what exists in the literature. It's the Society of Thoracic Surgeons model to make a prediction for length of stay, but they just group it, classify it as a short duration length of stay, a long duration length of stay. We came up with a model where we are able to do the prediction using neural net to within 1.6 days, mean absolute error is 1.6 days plus minus. However, the challenge is in implementation of the model. Not really the implementation. The model can be implemented, but will it be useful? Being able to predict the length of stay is good, but it does not change the clinical pathway or the decisions that the physicians are going to make. So yes, we've done it, but so what? Like, how do we use it? What is interesting though is that we were able to do that feature selection and find the most impactful variables that is driving the neural net. And we actually converted that into a simple regression model where the results are kind of almost similar. And this is easier to interpret, this is easier to implement, and it also shows exactly the variables that are relevant for predicting. So I thought this was an interesting research that we did. So in conclusion, we are cautiously optimistic. We are not overly enthusiastically just picking up the next AI solution that exists. It's a very thorough process to evaluate these things. And then finally, we feel that AI will not replace physicians, but physicians that use AI will replace physicians who don't use AI.
Yeah.
Thank you.
Thank you so much, Professor Tiwari, for walking us through very interesting presentation regarding how AI is not just a research concept, but something that we can truly shape the clinical operations and which can also improve the patient care when applied thoughtfully. And your work also shows that the future of AI in hospital is already here. It just need careful, ethical, and practical execution. So thank you very much once again for you sharing your valuable insights. And if I may, would like to ask the first question from you that your presentation highlighted how AI is also being used for operational tasks, such as like managing patient flow, documentation, and discharge prediction to managing to improve actually to the system efficiency. But as a hospital, increasingly relying on these tools, how do we ensure that they do not unintentionally reinforce disparities in care? And for an instance, if I may, like what safeguards or monitoring system that can be built into AI pipelines to ensure fair resource allocation across departments or avoid biases against patients from underrepresented groups or with less complete data records?
Yeah, that's a very good question. And uh, we are learning that the AI is just as good as it was trained on. And our populations often, the training populations often are not truly representative of the actual population, for example, that exists in our location at least, right? Somebody in California and in the Silicon Valley has developed that prediction model based on probably some other demographics that exist here. So that is definitely a question and a concern that we have, and it likely will grow as the implementations scale up. However, at this moment, because the decision anyway that the recommendation from the AI anyway is getting vetted through a human being anyway. There is no application right now that I can think of where we are blindly just using that recommendation. So the bias, if any, is likely getting auto-corrected through the human being. But yes, as we scale up, that's one thing that definitely is front and center in our mind.
Thank you so much, Professor Tiwari. Professor Jha, sir, your presentation made a strong case that building super intelligence from the bottom up uses far less energy than training large models with trillions of parameters, which is important for long-term sustainability. However, hospitals across the world have different levels of computing powers and face different electricity costs. So, how would you measure and prove that your bottom up approach really lowers the carbon footprint in real clinical settings while keeping up or even improving the accuracy of diagnosis compared to the top down model that many hospitals are already using?
Yeah, so that's very interesting because and it's very timely because the large language models have not just in training but also at inference time have started consuming a lot of energy. So one thing is our bottom-up super intelligence would be built with around 32 billion parameter models, not 2 trillion parameters. So that itself gives you 2 orders of magnitude energy reduction. Then the models will not be developed in the hospital. So the models will come elsewhere. They'll be trained on servers or CPUs, GPUs elsewhere. So only the inference will be done in the hospital. So we envision these 32 billion parameter models you can put on a smartphone. So smartphone is definitely going to consume orders of magnitude less energy than what you would need for a data center supported inference system, which is what the current AI industry needs. So energy consumption would be much, much lower with bottom-up superintelligence. What you're giving up is the AI industries after what it calls artificial general intelligence. To me, for AGI, you need both breadth and depth. The AI industries models, they have breadth, they don't have depth. So I envision a society of AI which is built like a human society where each of us has some domain expertise, but none of us is super intelligent. But together, as a society, we are super intelligent. Look at the progress in science and technology and medicine. As a collective, we are super intelligent. And that's where my inspiration comes from.
Thank you, Professor Jha. Dr. Padman, my next question is for you. Ma'am, you spoke about the conflict between platform algorithms that focus on clicks and the goal of the real health education. And as a collective, like how we can collaborate with the tech companies, regulators, and public health agencies to change the incentives, and how we can ensure that videos with accurate and easy to understand medical advices are ranked higher than those who are just like a popular. And if you can guide us on like what kind of policies and like data sharing agreement or public-private partnership might help platforms value clarity and correctness.
Yeah, thank you for that question, Shivam. No, this is clearly a very well recognized challenge that when you use social media for health information, we know that the content is not vetted, recommendations do not adhere to evidence-based guidelines, and so how do we ensure that what we recommend really, meets the needs as well as they are accurate, acceptable, and so on. So, in response to this concern, in 2021, the US National Academy of Medicine partnered with YouTube, for example, and this could be a model for other social media platforms as well. So, they partnered with YouTube to develop strategies for what they called surfacing authoritative content and evaluating the credibility of online providers of health information. And then in 2022, they assembled a small international advisory committee to develop the criteria, to I identified these credible sources of health information on social media, and I was selected to serve on that committee. And we came up with specific criteria for that was really targeted at, well, videos that are produced by for-profit organizations versus non-profit organizations versus individual sources like perhaps very well-known physicians and so on. And what are the criteria that we can use to evaluate the credibility of these sources? Now, clearly, implementing these criteria does require multiple stakeholders to come together and create an ecosystem that can credential the sources and their products and their recommendations and so on, that are then evaluated for adherence to best practices, guidelines, and so on. So, for example, what we see one such implementation is now, if you go to YouTube videos on health topics, you will see that they have implemented what is called an accreditation tag. If the video is produced by an accredited health entity, such as Vanderbilt University Health System or University of Pittsburgh Medical Center, there is an accreditation tag. It's like a watermark that says this is actually the video that's produced by this is a credible source, and the video has been vetted before it was actually uploaded to the YouTube platform. So this has to be extended to other useful and credible sources as well. So there are, all these stakeholders have to come together to be able to extend this type of an approach to all types of social media, whether it's discussion forums, it is TikTok, it is, all these other sources where health information is made available. But we do see an effort, beginning effort to try and curate this and credential it so that users and both consumers and clinicians can actually say, hey, this is really what you need to watch.
Yeah, thank you so much, ma'am. My next question is for Professor Dave. Sir, you have studied like how digital health systems grows in real life settings, especially in India, where healthcare is a very uneven, if I may say. And some cities have top hospitals, while the rural areas often lack even the basic cares. Based on your experience with working in the area of telemedicine, startups like Niramai and the platforms like eSanjeevani, what are the biggest lessons for building digital health systems that are both scalable and fair? And as AI tool becomes more powerful, how can we ensure that they still reach to the people who need them most, especially those who are in the village or those not comfortable with like much technology?
Okay, great question. Also very difficult to answer. Two, three things I'll say. First, our health-seeking behavior can be characterized as sort of breakdown maintenance. In India in particular, I think it's true in most cases. When some things go wrong, we seek help. Two, there is because of the Ayush practices. These are the South Asian origin practices, which are not similar to the allopathic practices as we call them. There are a whole range of healthcare options available to people which don't always match. They don't always work together. Of course, Ayush practices have now been certified by the government of India, and AI is being used, technology is being used in them as well, but they're very different. So scaling, I think national level scaling uh, can be done to the extent that is happening at the eSanjeevani level, which is basically a conference call. However, beyond that, I don't think it's possible. It will have to be done at the regional level, uh, taking into consideration the preferences, choices, understandings of people's health-seeking behavior, health behavior that is very local. That has to be taken into account. Now, how will AI intervene? I think AI will be adopted in ways that is suitable to those conditions. That is invariably going to be the case. The seeking, touching the pulse, the nadi as it is called in Indian, in some languages, is very important. And if an Apple Watch can help with that, it will get adopted. It will get used in those situations. But by itself, it may not work very well. So local conditions matter a lot.
Thank you, Professor D. My next question is for Dr. Vikram. So, sir, my next, with the context of like balancing the algorithmic performance with the clinical reliability, and as we know that one of the biggest concern when deploying AI in healthcare settings is that the models often perform very well in the test environments, but struggles in real world condition due to data noise, patient diversity, or workflow complexities. So, from your experience at Vanderbilt, like how do you strike a balance between technical performance metrics like AUC scores, as you mentioned, and the reliability and usability of a tool in real clinical settings? And do you often need to simplify the models for adoption? And if so, how do you navigate the trade off between complexity and the clinical trust?
I'll go back to that length of stay prediction for the CAPG patients, right? And we simplified it by showing that about similar prediction can be done using those variables that the AI found, which we can now use just through a simple regression statistical model, right? So it's a simple way to do that. And it's also easier to implement. But going back to your important point about usability, just because we can make a prediction doesn't mean that it's useful from a clinician perspective or even for and so being very cognizant about the workload that physicians have with the emergence of electronic medical records, it is very clear that they should be an aid and not a burden. So anytime we are implementing something, we are thinking about how many clicks will it take the physician to do this. And because we want to minimize their, we want them to focus on the right thing and not be scurrying about looking for information. And so this is an example where we were like, this will not be useful from any practical perspective, and we did not implement it. Going back to your point about the model reliability to the real reliability, I think that's why we have the randomized control trial in between. You got the model, it's running, it's working, it's better academically. We can show it's better than the previous ones. Now let's actually test it out in a true form, like make a prediction, make a physician is looking at the same patient, model is sending something in some information, two lines of treatments, which one is coming out to be better, right? So once that in real world, one that stands out, then it will get implemented, right? So that's why we have those steps in between.
Thank you, Professor Tiwari. My next question is for Dr. Padman. Ma'am, in your YouTube study, you use the PMAT guidelines along with human review to recommend videos that are easier for real viewers to understand. But viewers often have different reading levels like language skills and cultural background. So how could this system be expanded? So if not only selects clear videos, but also, like adjusting the subtitles, simplifying the explanation, or provide local language narration automatically, making the content more suitable for each viewer's need and abilities.
Thank you for that question. It's a complex process. In fact, there was a study done during the early days of the COVID at Dartmouth, where they found that all the information that were presented on health websites of the state health websites, including the CDC, which is the public, health website of the country of the U.S. The reading levels were at 11th grade and higher, when the CDC's own standards require this information to be at the 8th grade reading level. So clearly, this is a problem that exists with any health dissemination tools and promotions that you have. So what we are doing is, we already have published some work where we have looked at assessing inclusivity from a gender and race perspective while curating the videos using, for example, face recognition, narrative characteristics in the video. And now we are looking at extending those to take into account the diverse literacy levels, not health literacy, but functional literacy levels of the population, the language requirements, simplified explanations, and so on that you mentioned, but using real time translation tools. I mean, so we can, and these days, that's what we do when we travel worldwide. We use these translation tools on your mobile phone, and in real time, you are translating from one language to the other. So this is certainly feasible at this time. And also multiple languages, like I can think of a project going on in India called Bhashini, which is really allows you to translate to all Indian languages in real time. And then we can use Gen AI and LLMs and so on to do narrative summarization, video synthesis, and so on to meet the contextualized needs of the users. But of course, we have to keep in mind the problem of hallucinations when you start using those technologies. And also, another important constraint to address in this context is the intellectual property rights of the content creators, as well as the medical, misinformation, disinformation challenges, and so on. So it's not really just classifying the videos based on those criteria that I mentioned, but to really make it practical, at the point of care, we need to really address all of these additional challenges as well. But the technologies are, so many of them exist, and many of them are under development that we can certainly incorporate into what we are creating.
Yeah, thank you so much, ma'am. So, Professor Jha, you described using fine-tuned foundational model for different type of data such as text, signals, and images, rather than using one large multimodal model. So, in practices, this could mean that one model reads an X-ray report, another could analyzes the heart rate signals, and third could processes the patient notes. So, if these model produces different or even conflicting outputs, such as, if I may say, one suggesting a certain diagnosis, while others suggest something else. So, how will they compare their results and give a clear signal recommendation that a doctor can trust? And will there be a central coordinating agents, or do you expect the models to be eventually learn how to resolve these differences on their own? So, Prof, you're on mute, Prof.
Oh, sorry. I thought I unmuted. So when let's say there are three doctors and they disagree with each other, two of them says this person has type 1 diabetes. The third one says this person has pre-diabetes, does not have type 1. So when they discuss this with each other, they give each other reasons. A lot of the machine learning models are opaque. If you take a neural network, I don't know why it made that prediction that it made. So explainability becomes extremely important. Otherwise, physicians are not going to use it. Even if in the lab I say it's 98% accurate, the physician will still worry about the 2%. They don't want harm to come to their patients. So explainability comes from different sources. One, I mentioned knowledge graphs. So knowledge graph is a distillation of all the knowledge in that area. And when I'm making a decision with my AI agent, I can actually give you the reason. I can traverse the path on the knowledge graph and I can say this is the chain of reasoning that the AI agent went through to say that this person is type 1 diabetes. Now, once that reasoning is exposed to this committee of three people, so you can think of this AI as being the fourth expert, and then ultimately the humans will decide, but they will have reasoning that is backing the AI decision. So I think explainability, which is not that well advanced in AI currently, is key.
Yeah, thank you so much, Professor Jha. Professor Day, your work shows that the telemedicine succeeds in the low resource areas when there is more than just technology. And it also needs a strong internet access and training for like local doctors and support for the patients. But in many government programs today don't have these support systems in place. So according to you, how do you think that we can include these important elements like training, offline supports, and community network into national policies or like funding models so that they are seen as essential parts of the telehealth, not just an operational extra?
Yeah, great question. Also very difficult to answer. I'll say what Dr. Padman mentioned, fair bit of health literacy has to be imparted to the entire community. Uh, One of the things that many startups do, actually, hospitals have been doing this, is hold these health fairs. So you go into a region and you say, okay, free eye checkup today. Eye checkup is actually quite popular. Niramai, the company I mentioned, has been doing this for breast cancer detection because it's low cost. They can go into a region and do this. This builds awareness, this builds understanding, this builds also in the minds of the people who are maybe they don't test positive or anything, but they're healthy, that preventive maintenance is possible. As I said, we always go with breakdown maintenance. It also makes them aware of the other players in the local community. Sometimes you actually don't know who to go to in many cases. Like if you see primary, tertiary, primary, secondary, tertiary care, many people actually are not aware of tertiary care, what to do, where to go, actually even enter a hospital. Although hospitals have been working on this for a while, except some of them, many hospitals are, it's really scary to go into such places because you, especially when you are suffering, you're not in good shape, your family is very stressed. So these aspects have to be taught over a period of time. Many NGOs and civil society organizations are engaged with this, and I believe they are doing a good job. Of course, the scale isn't enough. It has to go much, much further.
Thank you so much, Professor Day, and thank you so much to all the professors. I can see that all the questions that have been put it by the audience have been already been answered. And as we are running out of time, slightly over time, so we won't be able to take more questions, like more follow-up questions. So thank you to the all respected professors for your thoughtful engagement throughout today's session. And this panel has brought together a wide range of powerful and practical insights on the future of healthcare and artificial intelligence. Professor Rema showed how digital tools like mobile games and health education videos can make medical information easier to understand and more accessible, especially for the children and undeserved population. And Professor Jha offered a new vision of AI and healthcare, not as a one large system, but as a group of smaller task-specific assistants that are transparent, interpretable, and more efficient, especially in the low resource setting. Professor Day reminded us that the technology is not only as strong as the system around it. He emphasized that the trust, training, and local support network are just as important as the AI tool themselves, especially when we are working in rural and underconnected areas. Professor Vikram brought a hospital's eye view of AI, showing us how smart tools are already improving operations from predicting patient flow to reducing documentation burden to improving material health outcomes. So together, today's discussion made it very clear that AI is not just about an algorithm or machines. It is about building systems that are thoughtful, human-centered, and designated to work in the complexity of real healthcare environment. So thank you once again for joining us. May I now request Mr. Venkatesh to formally close this session?
Thank you, Shivam. I take this opportunity to thank all the esteemed panelists for their valued presentations, great questions and great answers as well. We are really honored to have such accomplished professors today. The event was live streamed and we have many participants on the webinar as well in the live streaming, and we are sure this will be watched by many tomorrow considering the time of day today. And with your permission, we would also have this recording made available to many of our contacts here. And thanks all the participants. And we are sure that this was of great help to you. And in case you want to watch these, please contact us and we will share you the link. And thanks Shivam as usual for organizing this, all the great questions and the preparations. Thank you all. And have a good evening, good day to all
Thank
the
you.
participants and the panelists.